Hello.
Thank you, Dr. Ashutosh Gupta. Thanks to AMA for having given me this opportunity to chair this session. In this session, we have a renowned speaker from Delhi, and he is going to enlighten us on the subject of obstructive sleep apnea. Dr. Ashutosh Rai is going to introduce the speaker to the audience.
Sir, welcome. Good afternoon to the audience. I'm pleased to introduce the speaker today, Dr. Jagdish Chandra Suri, who is a renowned pulmonologist. He is the director and head of Department Pulmonology, Critical Care and Sleep Medicine at Fortis Vasant Kunj. He is also the member of the National Expert Committee on COVID-19, Ministry of Health, Government of India. He is consultant professor and head Department of Pulmonary Critical Care and Sleep Medicine, Safdarjung Hospital and Vardhaman Mahavir Medical College, New Delhi. He was also vice principal, Vardhaman Mahavir Medical College. He has been a renowned academician with numerous publications to his credit. He is a teacher par excellence leader at national and state IMAs. He has contributed immensely in various national medical projects. I'm happy to introduce him, and we are keen to hear his talk on obstructive sleep apnea. As you know, obstructive sleep disorder breathing is one of the very common, less diagnosed, and having serious mortality and morbidity condition. And it's interesting to know that obstructive sleep apnea is only found in humans. It's not found in animals. So please, Dr. Suri, would like to ask you to enlighten us on this very interesting subject on obstructive sleep apnea, or as a bigger term, obstructive sleep disordered breathing.
So before the session starts, I would request P.S. Singh ma'am to have few words about the origin as a customary, and I would request the speaker to take over from there.
I would like to thank the organizers of the AMACON to give me this opportunity of saying a few words for a person about whom I can talk volumes, because he filled everybody's heart. Anoop, as we all addressed him, was born on the 7th of April 1960 at MLN Colvin Hospital, Allahabad, to a humble, educated and God-fearing couple, Mr. and Mrs. P.C. Vari. Anoop started his education at the age of 5 and passed his high school and intermediate with flying colors. He then stood third in Allahabad University in BSc Part 1. In 1977, he qualified for CPMT, again holding a rank, and continued to do well throughout the MBBS course. It was during his internship that he developed rheumatoid arthritis and was forced into taking up pathology rather than a clinical subject. The Department of Pathology was only too happy to welcome such a brilliant student into our midst, and I assure you that his teachers and colleagues enjoyed every moment of his company. He was always happy, never complaining, humorous, ready to help anybody that came his way, and most of all, he was like a sponge, absorbing everything that he learnt during his lifetime with an eagerness that is worth mentioning. After completing his MD in pathology, he started a private lab single-handed and gradually brought it to a level that the investigation reports from his lab were readily accepted by institutions like SGPGI, AIMS, TMH, CMC, and TMC. Without batting an eyelid, his lab still continues to be by far the best lab in this district, with the presence of his spirit and the untiring efforts of his wife and other members of the family. I can speak volumes of this man, but time does not permit me to do so. I want to end by saying that God plucked this beautiful flower from his garden a little too early on the 2nd of August 2007, not before Anup imparted his fragrance to his family and friends, which is substantially evidenced by the institution of this oration in his honor and memory.
Over to you, Professor Suri.
Thank you, Chairman, sir. At the outset, I would like to thank Allahabad Medical Association and Dr. Ashutosh Gupta for giving me this opportunity, this privilege and honor. When Dr. Ashutosh asked me to give an oration, so the question of topic came. So I thought, since this meeting involves people from diverse specialities, a topic should be of common interest to all of them. Because once I go through my talk, you will see that many of the things you will yourself identify with this. Because this is a topic which cuts across these specialities. It actually affects each and every system of the body. So that's why it becomes very important. And the reason I have given this title, Sleep Disorder Breathing, a Hidden Epidemic, every physician must recognize. So that was the most important thing in this thing. And just to introduce these things, in the quiet hours of the night, while the world sleeps, a silent epidemic unfolds in bedroom across the globe. Sleep disorder breathing, particularly the obstructive sleep apnea, represents one of the most underdiagnosed yet consequential health condition of our times, affecting all age groups and both sexes. So this sentence in itself says a lot of things. It's linked to hypertension, heart disease, stroke, while significantly impacting quality of life and productivity. This paradox, what we say, is silent condition with profoundly loud health consequences, affects almost, if you take an estimate, which is about 936 million adults worldwide. Yet it remains largely invisible to both patients and healthcare workers. India's burden is rising with increasing obesity and urbanization, making recognition and management critical for every clinician. So that's what the introduction which I wanted to give. And to further stress on what I am saying through this introduction, I will take you through 2-3 case studies. The first case here you can see of a 52-year-old accountant. He is suffering from resistant hypertension. Resistant hypertension, when somebody is taking 3 or more drugs and still the BP is not controlled or maybe barely controlled. The patient on detailed history had excessive daytime sleepiness. There was a history of witnessed apneas, stopping breathing at night, relatively obese, BMI 32, and neck circumference 43. The patient was diagnosed with moderate sleep apnea. His AHI was 22, and after 3 months of CPAP therapy, BP was controlled on 2 medications. Energy restored and cognition improved. The another case, which is that of a child, as I said, all age groups and both sexes. This is a sleepy child, but the presentation was not sleepy, but basically it's a 8-year-old child presenting with poor school performance and hyperactivity symptoms that concerned both parents and the teacher. On physical examination, he was found to have upper airway obstruction in the form of enlarged tonsils and adenoids, and he had mouth breathing. Then he underwent a sleep study where he was found to have obstructive sleep apnea. The treatment and the recovery, the patient underwent adenotonsillectomy, and within 3 months of adenotonsillectomy, there was significant improvement in both sleep quality and daytime behavior. So that hyperactivity and behavioral symptoms significantly improved. So the key clinical insight here is that sleep disorder breathing can mimic ADHD. So this condition, which is frequently diagnosed by psychiatrists and clinical psychologists, attention deficit hyperactivity disorder. So sleep apnea is one condition which can mimic ADHD in children, making accurate diagnosis crucial for appropriate treatment and results. The third situation here is that of an old lady. Now, this lady, which is she's about 68, 69 years old. She presented with frequent falls, confusions, and hypertension. There are no symptoms suggestive of sleep apnea. So she underwent a sleep history where it was found that she had a mild snoring. The bed partner witnessed apnea. She underwent sleep study. The diagnosis of sleep apnea was made, and after that she was put on CPAP, and within 3 months there was a significant improvement in her cognitive functions, and the falls became much less. So the moral of story here is that this patient does not have any typical symptoms. It presents with what you call geriatric symptoms of frequent falls, confusions, and when you take a detailed history, you will see that there is some evidence of sleep disorder breathing, and on treatment there is significant improvement. So what is important is awareness on the part of the physicians to look for these things, whether general physician or whosoever is carrying these patients, geriatricians, physicians, neurologists. So with these 3 cases from diverse age groups, I will start my actual presentation. I am going to give you an overview about the epidemiology, clinical features, the consequences, which are mainly in the form of cardiovascular and metabolic and cognitive functions. Then I'll give you a little bit about the diagnosis and treatment, and highlighting in the end that it is the multidisciplinary approach which is very important in the management of these these patients. So if you look into the global epidemiology, in US and China, where is the highest in prevalence, which constitute about 30 to 35%. In India, it is between 13 to 17%. And we see the male preponderance, means 2 times we see in males than in females. The major risk factors are obesity, increasing age, the craniofacial features, particularly which makes our pharynx, which is anatomically small, whether it is due to hypognathia, micrognathia, or enlarged tonsils, adenoids, or due to obesity and deposition of fat in the lateral pharyngeal walls, enlarged tongue. So all these things can lead to anatomically small pharynx. There is a family history. The obesity is more important here, is the central obesity, which you can see with the neck circumference, and which is we have 43 centimeters in men and more than 41 centimeters in women. So these are the important factors. So what does this indicate? That means about 30% of the people, and if you want to take Indian population, 25% of the general population will have some degree of obstructive sleep apnea, in which you can say about 15 to 20% will have moderate to severe obstructive sleep apnea, which is associated with long-term consequences. What is the clinical gap? The clinical gap is between recognizing these patients and what they are actually present in the population pool. So if you see the total population pool, about 80% of these patients which have moderate to severe disease will remain undiagnosed. And those who are diagnosed may not get the adequate treatment. So that's a very important thing, So 80% of these patients, because their presentation is so varied according to the age group, that I think the most important thing is recognition. So you see every day so many patients in your specialty. What you have to do is to look for that sleep angle. So whether the treatment of diabetes, hypertension, or it is gestational hypertension, whether there is a sleep angle to it, whether the patient has sleep disorder breathing. So this is frequently missed because the symptoms are not recognized. So these are I think the most important thing which I wanted to mention. About the clinical features by population, I would say that you must recognize this disease across the age group and the gender. It varies, right from childhood to elderly, you won't find commonality in their presentation. So that's why it becomes so difficult to recognize this problem. So the first group, if you will see, are the children. The children, 5 to 10% of the children have obstructive sleep apnea, and the most important cause is, of course, enlargement of adenoids and tonsils. What is their clinical presentation? With what these patients will? They will come with behavioral problems. They will present with hyperactivity, poor school performance, and growth retardation. So there is a lot of concern by school teacher or the parents that their child has a lot of behavioral issues. So with that, most of the time they are diagnosed with ADHD, and they are being treated by clinical psychologists. But if you take a detailed history in these children, you will find that they have a lot of sleep issues. They have sleep apnea, they have snoring, they have mouth breathing, they will sleep in that typical what you call knee-elbow posture. So that's the typical sleep position the children usually have. And they are very restless sleeper. These children will keep moving. They are not the one, sleeping like a baby. So they are the one who are moving on the bed, and you will see the whole bed sheet crumpled, and they are having excessive sweating. And this is the position which keeps their upper airway open so that they can breathe at night. So this is one typical presentation. The adult, that's the classical presentation, the classical triad of excessive daytime sleepiness, witnessed apnea, and the snoring. So loud snoring. So when you talk about snoring has its own language, So if snoring is very mild, then it can be just simple snoring. But any snoring which is very loud, which can be heard in the different room or a different floor, what we call as the heroic snoring, these are the people who have a very high chance of obstructive sleep apnea. And there is also a lot of gender difference in snoring. The female snoring is very soft and is even frequently missed by the bed partner. So when you are asking for snoring, so asking a male and a female, there is a huge difference, so you don't expect the snoring is going to be similar between males and females. So so the classical triad of snoring, witnessed apnea. Witnessed apnea means the bed partner will notice that person stops breathing. So there is snoring, then there is a silence, and there is a resumption with a snort. and then patient starts breathing. And so that's the kind of a picture, we call it as the witnessed apneas. So that is what you will see. Of course, there are other features like, I'm sorry, I forgot to bring my glasses, so I can't see that clearly. So restless sleep, nocturia is a very important thing, and many of these patients are diagnosed as BHP. So they are put on treatment for benign hypertrophy of prostate. So the number of times they wake up in the night actually correlate very well with the severity of sleep disorder breathing. So that's another very important thing. So then of course impaired concentration, mood disturbance.
Hello.
Not working? I think it's not working. That your collar mic. Yeah, I can take this. So these are very important presentations. Loss of libido, impotence. These are patients going into the urology department, and this sleep apnea is frequently missed. But this is one group where symptoms are classical and they should be very easy to be diagnosed. The next group comes the elderly group. I showed you that clinical case, and these patients usually present with geriatric symptoms, the geriatric syndrome, frequent falls, memory lapses, confusions. That's the way, and they may have minimal symptoms, but they have a lot of comorbidities, because at that age patients may have hypertension, diabetes, coronary artery disease. They are on polypharmacy. So many drugs they may be taking. So all this makes the thing so confusing, and this thing. And if you see, the prevalence increases with age and affect up to 70% of individual more than 65 years. This is a very important statement. That means individuals more than 65 years, 70% are going to have some degree of sleep disorder breathing, and maybe 40-50% may have moderate to severe disease. So again, you will have to recognize, pick up, do screen or do the diagnostic evaluation and treat this patient if you want to treat their symptoms of so-called dementia. Because most of the time you will think that it's a part of growing. It's because of, as we are growing older, the symptoms are coming. So it's an overlooked population. That's very, very important. And then we go to the gender difference, the women. Now women are to some extent protected during the reproductive period, because of the estrogens and this thing. But after menopause, the prevalence is same as men. In fact, the problem is much more severe in women than in men. So, what is the clinical presentation of a woman? Again, not with sleepiness, excessive daytime sleepiness. They'll present with fatigue. They'll present with insomnia features because of the sleep apnea, and each time sleep apnea is terminated by an arousal, so they feel as if they are not sleeping. There are frequent arousal. There is a sleep disruption they have got. So they'll present with fatigue, tiredness, insomnia symptoms, morning headaches, and mood disturbance and depression-like symptoms. So they again land up into the psychiatrist's chamber being treated for depression, and when you see that they may have. So if you take a history, do you snore? The answer will be no. Because female snoring is so soft that it is, even if you ask the bed partner, they say it is not noticed. In fact, the bed partner may be snoring much heavily than the patient. So this is a very important, again, picture which needs to be picked up, because every day I see so many female patients, particularly around the menopause, the hormonal changes takes place, there is a weight gain. Now this time when the weight gain occurs in females, it is different anatomical distribution. So the weight comes around the abdomen, and there is central obesity, and they start snoring, they start developing features of depression, they also
are diagnosed with hypothyroidism. So those are the things, and there is onset of hypertension, breathlessness. And if this is undetected and untreated, they will develop a diastolic dysfunction, concentric LVH, diastolic heart failure. They'll become edematous and they will develop breathlessness on exertion, being treated as asthma or other things. So these are the way, the patients are being treated because their primary condition is not being picked up. And it is the background, it is the situation, it is post-menopausal. So you have to be aware of all these things, Because if you do their echo may say mild concentric LVH, maybe grade 1 diastolic dysfunction. But in this age group, that may be significant because if they are simultaneously edematous, there is a fluid and you may find basal crackles. So this is how they may present with the features of dyspnea, and they may also have fatigue, tiredness, depression-like symptoms. The picture is very, very diverse and needs to be picked up. And the last group is the pregnancy. It's a double jeopardy here. The pregnancy, as I told you, there is a weight gain, there is edema, there is a congestion of the upper airways. So these people start snoring. So 8% of the pregnant women snore. So what is the consequences? How does it matter if a pregnant woman is snoring or this thing happens? They start developing gestational hypertension. So gestational hypertension and symptoms of preeclampsia, very commonly associated with, again, sleep apnea. So you could see the impact of sleep apnea in diverse age groups and this thing. And there is also fetal outcomes here. But the fetal outcomes here you can see is the intrauterine growth retardation, preterm birth and low birth weight, and greater likelihood of unplanned NICU admission. So these are very important situation for obstetricians and gynecologists, because I can say all people with diverse speciality, when you see your patient and the patients are not responding adequately with the standard treatment, always look for a sleep angle. So there may be something which is feeding this problem in a way that the standard treatment is not adequate in controlling it properly. So this is about the clinical presentation which I wanted to mention. So next thing, the consequences. So this is actually all age groups. I can leave it, I'll not go, because each age group, the etiopathogenesis is different. In children, it is adenotonsillar enlargement. In adults, actually, it is the obesity. In elderly, it is loss of muscle. So elderly people may not be obese. It is the decrease in the muscle tone of the upper airway, pharyngeal dilator muscles, which make them prone to develop. So they are atypical sleep apneic. So that's what actually I wanted to show you in that comparison. And what is the pathophysiological consequences? So as you have frequent breathing pauses during the night, the breathing pauses are associated with intermittent hypoxia. So when there is an arousal, the patient breathes heavily and actually it overventilates. So there is hyperoxia. So there is a combination of hypoxia during obstruction when the patient is not breathing, and then there is hyperoxia because in the second phase they hyperventilate and oxygen levels actually go up and they cause oxidant injury. So most important thing is recurrent hypoxemia and reoxygenation. Then with arousal there is sympathetic activity, and there is also activation of coagulation system with adhesion molecules, and there is a state of chronic inflammation, low level inflammation. So you'll see CRPs and other markers of chronic inflammation going up in these cases. So with this they become prone to develop hypertension because it is a hypersympathetic state. There is an increased inflammation. There is hypoxia, hyperoxia. So all these things lead to, most important is the cardiovascular consequences. The cardiovascular consequences are hypertension, arrhythmias, heart failure, stroke, and metabolic. are the diabetes and the uncontrolled diabetes and what is the metabolic syndrome. Then we have neurocognitive features, memory impairment, mood disorders, and accident risk also increases. Because of the intermittent hypoxia, the brain also doesn't get oxygen adequately. So these people start developing features of early dementia. So that's what is an important aspect for these things. So if you see hypertension, which is the most important comorbidity of obstructive sleep apnea. So 80% of OSA patients have hypertension, 50%. So if you have your hypertension patient who you are treating, your 50% patient will have obstructive sleep apnea. And that may be contributing to poor control of blood pressure. That's one. 30% of hypertension patients will have OSA. And if you have resistant hypertension, where the patient is taking 3 drugs or more, 80% prevalence of moderate to severe sleep apnea. So they may not respond to standard therapy and may require evaluation and treatment. So CPAP reduces blood pressure by 2 to 10 millimeter, and heart failure is another because it's a bidirectional relationship. So obstructive sleep apnea is associated with heart failure, and heart failure in turn causes obstructive sleep apnea, which is a central sleep apnea. So both these patients will have obstructive sleep apnea causing heart failure and heart failure causing central sleep apnea, and what you get is complex sleep apnea. So complex sleep apnea is much more difficult to treat than simple obstructive sleep apnea. Then another very important factor is the atrial fibrillation. So if you are looking into the arrhythmias, it's okay. So atrial fibrillation is a very important arrhythmia, and you see so many cases of atrial fibrillation. And again, you will see that there is a 3 to 4 times increased risk of moderate to severe OSA in these patients. And what you do for these patients, you give the radio frequency ablation. But after these standard treatment, there is a frequent recurrence. So if you treat this patient, if you diagnose obstructive sleep apnea and treat, then the success with radio frequency is much more prolonged and persistent. So this thing. So that's very important. And again, strokes. Stroke is also, there is a bilateral relationship. Obstructive sleep apnea is associated with strokes, and then stroke may be associated with both obstructive and central sleep apnea because of the impact on the central respiratory center. So these patients may develop. And if there are neurologists in this audience, so if some patient develops stroke, so it is very important to screen these patients for the presence of both obstructive and central sleep apnea. And if it is not detected and treated, it can impact the outcome of stroke very poorly. So that's a very important message here one has to take when we talk about the impact of this condition. And of course, this is the metabolic disorders. There is a significant increased risk of diabetes mellitus. There is an increased insulin resistance. Also, now recently, this non-alcoholic fatty liver disease. The non-alcoholic fatty liver disease is frequently associated with moderate to severe obstructive sleep apnea because of this intermittent hypoxemia. So these patients, if they are taking alcohol, this is a non-alcoholic variety. So obesity and OSA, this combination leads to progressive fibrosis of the liver. So this is, I think, a very important aspect which one has to look into this thing. So next, now we have talked about prevalence, we have talked about clinical pictures, consequences we have talked. Now next we will talk about so little bit about the neurocognitive. I have mentioned the cognitive impairment and depression and anxiety. These two things again are very frequently associated. So if a patient has resistant depression, they are not responding to number of antidepressants, you must look for obstructive sleep apnea as a contributing factor and needs to be treated before these patients become better. Of course, the accident risks will also be significantly increased, and they are both at the workplace. Safety is also affected, occupational injuries are more common, and absenteeism are quite there in these patients. So how do we diagnose these patients? So all of you should, those who are physicians, should have some screening tools, which give you a fairly good idea that this may have obstructive sleep apnea. So there are two. One is what is called stop bang questionnaire. This stop bang questionnaire has, as the name suggests, STOPBANG, snoring, tiredness, observed apneas, blood pressure, BMI, age, neck circumference, and gender. So this, if it is more than 3, there is a high sensitivity for moderate to severe sleep apnea. If the score is more than 5, there is high specificity, 81%. If score is more than 7, there is 81% probability of severe disease. So more than 7 means all of them are there. So this patient has not moderate to severe, 80% chance that this patient has severe disease. So this is one, I think, screening tool we can use. Then of course there are other. This screening tool, this stop bank, is being used by anesthesiologists as a part of their preoperative evaluation to screen for obstructive sleep apnea. The another one is what is a Berlin questionnaire. This is a questionnaire which have been developed by primary care physicians. So if you, at the primary care, when you want to screen the patients for sleep apnea, the Berlin questionnaire is there. And in this you have this high probability and low probability of sleep apnea. So that's what you can see. And of course there are questionnaires for different age groups, because different age groups have different types of clinical presentation. So you cannot use one questionnaire for everyone, So there is a pediatric sleep questionnaire is there. Then of course there is Epworth sleepiness scale. The Epworth sleepiness scale is basically to judge how much sleepy you are in the usual circumstances. And in this, there are 8 questions with 0 to 3 marks, and so maximum score is 24. So anything more than 10 is considered to be excessive sleepiness. So all these tools are there, and they have varying specificity and sensitivities for the diagnosis, this thing. Clinical examination, of course, Mallampatti score. So I don't know how many of you are aware of this Mallampatti score here. So if you see here, normally you should be able to see the posterior pharyngeal wall, the soft palate, the uvula, anterior and posterior tonsillar pillars and tonsillar beds, the tongue. So this is what. But when there is a large tongue and the pharynx is anatomically small, you may not be able to see, you may be able to see only hard palate. The soft palate is not visible, the uvula is not visible, you can't see the posterior pharyngeal wall. So this is called Mallampatti 3 and Mallampatti 4. This is Mallampatti 4. So this again also gives you fairly good idea that this patient has a high chance of obstructive sleep apnea. One thing here I would like to say that not all patients with Mallampatti score 3 and 4 will have sleep apnea, because there are compensations. So some people are able to increase the activity of pharyngeal dilator muscle and keep their upper airway open during sleep, but others not. So, but their presence in the background where you are suspecting obstructive sleep apnea definitely increases the chance of this thing, And what about, this is of course, the tonsils. You see grade 3 and the grade 4 tonsils, which is very important feature in children. In children, the important thing, how you want to pick up enlarged adenoids and tonsils. If the adenoids are enlarged, the nasal cavity is blocked. These children cannot breathe through their nose, so they become mouth breather. So you must see, the breathing pattern. So in normal nasal breathing, they will breathe through the nose and their mouth is closed. But in mouth breathing, the mouth is open and breathing pattern changes. And this results into poor growth, because if you have nasal blockage, and if you breathe through the mouth, what will happen? Imagine yourself breathing from mouth with your mouth open. What happens? Your tongue loses its contact with the hard palate. So children, normally in children, the maxilla grows with the contribution from the tongue. The tongue pushes the hard palate, and with that the maxilla becomes wider and their upper airway becomes much wider. So once these children develop adenoids, and adenoid age is 4 to 6 years. That's the peak of age group in which they develop adenoids. And the growing phase, if they are mouth breather, their face growth changes and they develop what is called long face. In the long face, they have narrow maxilla, high arch palate, and their upper airway is anatomically small. So here, normally if you see the maxilla, the horizontal diameter of maxilla will always be more than mandible. But in these children, you will see that the maxillary diameter is less than the mandibular. So children, if you see, so that means the growth changes are already taking place. So what is important here is to pick up these adenoids early and remove them early. Because many times pediatrician, ENT people say, okay, let us not remove it. Let us wait and watch. Let them regress on their own. By that time the damage is done. Because all the growth phase affects, there is a change in the facial growth in these children. And that is what you see. And most of these children, you will see their teeth are not properly, these crooked teeth, going up and down. You can see the narrow maxilla, this is narrow maxilla, high arch palate. And once that happens, the damage is done already. So you have to pick up them early, treat them early. There is a lot of resistance on the part of the patients, parents, not patient, of course, parents, and doctors to refer this patient for early adenotonsillectomy because of the thinking that it will impact their immunity. It is something which is self-limiting, it's something which will go. But by the time they resolve, it is 11 or 12 years of age, 90% of their face growth is already taken place. So that's something very important you have to see, because if you can prevent a child developing this, you have done a great service to that child. Great service. His academic performance, this child's growth, face growth, everything will change if this is not picked up early and treated. That's what I want to stress here, So these are the things which require a lot of change in our mindset, change in our approach to various things, and how it is impacting the overall health of the child. These children become behaviorally very abnormal, very aggressive, and academically perform poorly. So these are the important things, and of course, screening for comorbidities. So once you think your patient has got, the two ways you can approach your patient to look for sleep apnea. One is through the comorbidities. All patients with hypertension, coronary artery disease, congestive heart failure, diabetes, obesity, depression, so cognitive decline, rapid cognitive decline. All these patients, you look for sleep apnea. Or if you have sleep apnea, look for blood pressure, fasting glucose, lipid profile, BMI, ECG, ECO, all this, because it is going to impact. And even if you see in an echo, early diastolic dysfunction, grade 1, mild concentric LVH, it is actually the sleep apnea. And if this is not within the domain of thinking of a cardiologist, it can be easily, ignored. And then over a few years, it will become grade 2 diastolic dysfunction, and they develop diastolic heart failure and dyspnea, and all these things, So this is, again, another very important things. And then, of course, for definite diagnosis, polysomnographies, we have 4 types of polysomnographies, here, level 1, level 2, level 3, level 4. Ideally, we should be doing level 1 polysomnography, which is done in the lab under the supervision of a technologist. It has all the channels, and level 3 has been actually designed without sleep, only cardiopulmonary channels. Basically, you want to diagnose these patients early. So if you have a lot of referrals and you want to diagnose them early so that you can give them early treatment, the benefit of the early treatment, then it is okay. But in an early situation, in Indian circumstances, your lab is not that busy, you always should do level 1 polysomnography. Don't go for home sleep studies, because those home sleep studies are not seen by any doctor. Nobody is going through their raw data, nobody is validating them. It is a computer software generated report, which is only 60 to 65% correct. And you don't see so many other things, which are very important to be seen in these cases. So that's the message I would like to say, that don't encourage any company person to do your sleep studies and give you report and give auto CPAP. That is not the treatment. Then there is no need for doing anything. There is no intellectual input the doctor is giving. So you are telling company person, go and do a home sleep study and then giving an auto CPAP. Where is the doctor's intellectual input here? Nothing, zero. So you have to see these patients and do it very well. And of course, these are the different tests. In the interest of the time, I am just going faster. The treatment for all moderate to severe condition. So what is a moderate to severe? This is the basis of apnea hypopnea index. That means the number of time the person stops breathing. So if it is normal is less than 5 to 15 is mild, 15 to 30 moderate, and more than 30 is severe. So CPAP is the treatment of choice because it creates a pneumatic sprint and keeps the upper airway open during sleep, and this has been found to be associated with significant improvement in the patient's symptoms, And of course, there are other things besides apnea hypopnea index, the oxygen dissociation index, then the time patient spends below 90% oxygen saturation. So all these factors are there, and then of course there is a lot of compliance issue with CPAP. So now there are very good techniques, the behavioral methods by which we can improve the CPAP adherence in these patients. And of course, this auto CPAP, this has actually destroyed the sleep medicine, because if you will just give auto CPAP to everyone thinking that it will adapt on its own and treat, then you will not see the records, you will not look into the other aspects. There are 40% of the patient may have complex sleep apnea, not only obstructive, that will be missed. So auto CPAP should be only used after home sleep study to titrate for pressure for fixed CPAP. So auto CPAP indications are very, very little, when particularly if the sleep apnea is position dependent or only during REM sleep. So then of course you can give, so that you don't have to give this treatment throughout the day. So the oral appliances you can use for patients with mild to moderate disease, but not with severe disease, because what is actually happening? So when you use CPAP, it will push the tongue forward and keep the passage open. The other way is you pull the tongue forward. That is with this, so that you can keep the upper airway open. The space behind the tongue can be kept open by pulling the tongue or the mandible forward. Because when you pull the mandible forward, the tongue is attached to the genu of the mandible. So this can, how much protrusion you can do would depend on the number of millimeters space you have to create. So that will increase with the severity of the disease. So one can sleep with the protruded mandible only if the requirement is not more than 2 to 3 millimeters. So it works only for mild to moderate cases, and particularly useful for patients who refuse CPAP. And of course, there are surgeries now there, which of course are not the first line treatment. The uvulopalatopharyngoplasty, the tongue-based surgeries, and hypoglossal nerve stimulation, these are there. They should be used as palliative procedure, where CPAP fails, where orodental devices fail. And of course, the bariatric surgery, because one of the very important risk factor is obesity. So to treat obesity, you can use bariatric surgery for these things. In pediatric OSA, of course, the most important thing is adenotonsillectomy. Now, when you do adenotonsillectomy, whether the child will not become normal or not would depend at what age you do the adenotonsillectomy. Because If you don't do adenotonsillectomy at the early stage, the facial growth will be affected. Suppose the patient started having a large adenoid at the age of 5 and he was a mouth breather, and you do the adenotonsillectomy at the age of 8. By that time, already narrow maxilla, high arch palate has developed. So first thing you do is adenotonsillectomy, and then you use these dental procedures. So with this dental procedure, you actually, RMI, rapid maxillary expansion, you open up the maxilla again. Of course, this can be done only before the age of 14 or 15, till the mid-palatine suture ossifies. Only then you will be able to do that. And of course, even after doing these procedures, if the child continues to have upper airway obstruction because the not grown adequately, then CPAP is the treatment. So this idea one should have, for pediatric sleep apnea, how we are going to do this. Other methods are, of course, positional therapies. So another thing with children is once they become mouth breather, even if you improve their upper airway obstruction, they remain mouth breather because they become habitual mouth breather. Because at the age of 3 or 4, they started breathing through the mouth. And at the age of 8, if you remove the adenoids, for 5 years of life, they have been breathing through mouth. So they won't change their breathing. So then you have to restore that nasal breathing. And there are myofunctional therapies now which in improving these things. So just 2 minutes, I'll wrap up. So what is the role of general physician for the OSA management? Of course, in this, what you have to do is high-risk population screening, obesity, resistant hypertension, atrial fibrillation, uncontrolled diabetes, congestive heart failure. All these patients need to be screened early, and with this, general physicians, primary care physician can help us. And of course, then the specialty. Cardiologist should help in detecting if they have resistant hypertension, atrial fibrillation, heart failure. Geriatricians, frequent falls, confusion or cognition, depression symptoms. Endocrinologist, type 2 diabetes, uncontrolled, obesity management cases, metabolic syndrome, diagnosis is there. Pediatrician, hyperactive children, chronic snoring, behavioral difficulties, growth failure, and obstetricians and gynecologists, gestational hypertension, preeclampsia, and pregnancy-related breathing problems. So these are the important things I think we should do, and I will just go to my last slide. We need a multidisciplinary approach here. You need a sleep specialist, primary care, ENT, dental sleep medicine, a cardiologist. So all these things are important, and in future these wearables and technologies are also going to help us in improving these things. So just few common myths and misconceptions. The common misconception, myth, that OSA only affects overweight older men. No. Second myth, snoring is just annoying, not medically significant. Myth, CPAP is the only treatment. Of course, we have so many other methods of treatment here. And the key takeaways here, are that 936 million adults affected globally, with 80% undiagnosed. A true silent epidemic. Multi-system impact. Obstructive sleep apnea affects cardiovascular, metabolic, neurocognitive, and overall health and quality of life, with significant morbidity and mortality. The treatment options, multiple effective therapies for each age group beyond CPAP, and personalized treatment is on the way. Varied presentation, the clinical features differ across population. Know the atypical presentation, and simple screening tools if you use, like stop bang, can identify high risk patient. And I am sure with
with the cooperation of all people with all specialities, there is going to be a bright future for the diagnosis and treatment for this particular condition. Thank you very much for your kind attention.
Thank you, sir, for the wonderful deliberation. I think as a customary, we will not take any question answers for the oration.
Thank you, Professor Suri, for your brilliant talk. As ENT specialist, I'm very happy that you have described so many ENT problems in detail. Do you know that famous music director Bappi Lahiri died of obstructed sleep apnea? The typical physical personality, short stature, obese, hypertensive, diabetic, and a lot of fat around the neck. A typical appearance of these cases. So, a multidisciplinary approach is required for management of these cases, including ENT specialist, pulmonologist, neurologist, psychiatrist, child specialist, dietitian. With this combination, we can provide a better life to these patients. Thank you so much. Any questions?
Yes, sir. Weight reduction सबसे पहले, sir.
Thank you, sir.
Thank you. I would request our chairpersons and the speaker to come downstairs for the felicitation.